So we go on to our next star speaker, Dr. PHAIK, and she's going to take us through again amazing set of videos in late in the bag IOL dislocation management options. On to you, doctor.
Thank you, Chitra, for inviting me. So let's go to some videos now. These are my financial disclosures. So there are many management options, and in this patient here, I'm just going to recycle this IOL. The lens is dislocated within the capsular bag. As you can see here, it's dangling into the vitreous cavity. And from clinical examination, I've recorded exactly where I can find it. And iris hooks help to expose where I can grasp the IOL without grasping any vitreous. And it's very important how you handle the vitreous when you bring the lens up. So in this case, I'm doing dissociated vitrectomy, 23 gauge coming in from the limbus. And I strip the capsular bag because I'm going to iris-fixate this 3-piece IOL. And I release the hooks with one hand by pushing the hook towards the center of the eye and then lifting it up and myosing the pupil with 2 paracenteses. I then pass this curved PC7 needle. All right, it's a 10O polypropylene. You can use 9O polypropylene. And this goes round the haptics behind, and then once I've got 3 passes done with a suture sliding knot, I make sure the IOL is centered before I tighten on that suture, and then do 3 1-1 knots, and then push the optic gently back, and then we have a nice round pupil. And I do that peripheral iridotomy, which is very important to prevent a pupil block and optic capture. Now, this patient has got retinitis pigmentosa, and I myself did the cataract surgery with a single-piece lens. I did not use a capsule tension ring at that time of surgery, and you can see his whole lens is beginning to decenter, and I'm going to fixate this using Gore-Tex suture. So this is a single-piece acrylic IOL within the capsular bag, and this is using Gore-Tex 7O suture, which is also known as CV8, pre-threaded in this 26 or 27 gauge needle, which you can use through the Hoffman pocket, going 2 mm posterior to the limbus. And I use that as a suture snare. So I extend that loop of suture, which I threaded, and I use that to retrieve a short length of free Gore-Tex suture. Again, this is the suture snare going behind the haptic through the capsular bag, retrieve that loop out to act as a lasso to bring in a short free segment of Gore-Tex suture to the Hoffman fixation point, and then using the suture snare now to pass above the haptic, and the other end of the suture then is brought to the Hoffman pocket. We then retrieve the sutures through the Hoffman pocket using a Sinskey hook, and we do this for the other side. So it's important that these 2 points of fixation are diametrically opposite and equidistant from the limbus. So it's usually 2 mm, and then I tie the 2-1-1, okay, so because it's a bulky knot, and then it slips into the pocket. Now this patient is a very high myope and has a dislocated single-piece PMMA lens. And you can see it's a very big optic. So I decided not to remove it. So I did some limited vitrectomy so that where my sutures pass, I'm not going to catch vitreous. This is using Calabrava's technique with a suture round like a belt loop. So one behind the other, 2 mm posterior to the limbus. And this is 6O polypropylene, one going from behind the haptic and the other going above. And we're doing this for the same thing, diametrically opposite, just passing a short segment of 6O polypropylene into this free 27 gauge needle that has passed through the capsular bag behind the haptic. And then the other end of the suture passes above the haptic. And so the lens is still within the capsular bag. And we then do the peripheral iridotomy again, which I think is a very important step. And then we flange down the 2 ends of the suture after tightening it and making sure that it's buried deep within the conjunctiva. So this patient has a toric IOL, which is dislocated, but the other side of the zonules are still intact. And so we're going to preserve this lens. So I first mark the axis that this lens should be sutured to. I then support the capsular bag. So with these hooks, I ensure that the toric alignment is appropriate. I even able to open up the capsular bag and remove some of the old lens material. I'm now going to insert a capsular tension segment. All right, this is 5 mm, in the extent of the arc. So it's important to open up the capsular bag wide enough. And if you are unable to do that, then you can't use this, but you can use an RC anchor, which is far narrower. So again, with the suture snare, we extend that lasso loop out of the eye, thread the end of the suture that is bored by the capsular tension segment through it, and bring it to the scleral fixation point through the Hoffman pocket, and repeat this for the other end of the suture on the capsular tension segment. And then we retrieve the sutures from the Hoffman pocket, and we tie 2-1-1 knot, adjusting the tension to suture to center the IOL. So you need to always tighten a little more. Now this is the last case, and in this case, I'm not going to recycle the lens. I'm going to exchange this lens. It's a 3-piece IOL, but I'm going to use the Canabrava technique, the Yamane technique, which is really my preferred and go-to technique in these eyes. So you can see here a 3-piece IOL, which I retrieved, and we're going to cut it and then explant it, having fluid running in the eye and some dispersive viscoelastic to protect the cornea. After doing vitrectomy, I then AIOS the pupil, implant this 3-piece sensor lens into the anterior chamber, and make sure that the pressure at the back is adequate. So I feel some BSS posteriorly so that the lens is in a good plane that I can reach, going 2 mm from that pre-marked point, which is again 2 mm from the limbus, which is diametrically opposite. I pass the 27 gauge needle, which is bent, and then I repeat this for the diametrically opposite side to retrieve the haptic. So you can see the haptic being pushed into the bevel of this needle. It's important to try to maintain the lens position and not overextend this haptic, which can sometimes kink because this is a PMMA haptic. Of course, if you have PVDF haptics, that would be preferred. And then you flange either end, and you flange it to a similar extent. So I normally grasp where I want to flange it down to. And before you push in the flanges, you just check to ensure that you're happy with the lens position. It's not tilted and it's well centered. You then push this into the beginning of the scleral tunnel. Don't push too hard. I've actually pushed it right in. All right. And then you have the peripheral iridectomy there, and you have a very well centered and secure lens. So in summary, it's important to ensure that you can retrieve the LL in subluxated lenses, and you can clear vitreous safely, and diluted triamcinolone always helps to visualize vitreous so that you remove every strand. And when you grasp the IOL, do not pull on the lens until you have cut the vitreous around. And then the easiest technique, which I showed you, really is iris suturing, like Dr. Hari Priya has also shown you. But the technique that I prefer today is really an intrascleral haptic fixation because it is so secure. And it's the technique that I would definitely use. If you have various techniques up your sleeve, then I would use the intrascleral technique whenever you're dealing with a post-vitrectomy eye, because there's no vitreous to support the lens, and there's really a lot of donosis of the IOL. If you failed at iris fixation, I do not redo it, especially if the iris has been traumatized before. And I prefer generally the flanged IOL if you've got a very large white to white, more than 13 mm, rather than using a glued IOL technique. And also the flanged IOL is really preferred if you have to spare the conjunctiva in cases that are having glaucoma that may require surgery. Thank you very much.
Thanks a lot. That was wonderful as usual, amazing. And we saw all surgeries which we can learn to do or which we'll never learn to do. So, and that was a simple question for all of us. Like in cases where there's a possibility of a progressive zonular weakness, like in pseudoexfoliation, have many of us started doing placing IOL in the sulcus with the CTR in the bag and doing an optic capture. Would you suggest that we should be handling those kind of cases like that?
Generally for me, I still place it in the capsular bag, and very often it's because I use a toric lens. So, I don't consider offering the patient a 3-piece lens in the sulcus, but of course we warn the patient that, over time this lens may decenter, and I usually do implant a capsule tension ring at the time. It makes it easier to dissect out the bag should I want to put in a capsule tension segment to preserve that toric lens.
Yes. Any other thoughts among the expert panel? Have you all ever thought that earlier days where we used to do a can opener, the possibilities of capsular phimosis was much less those days? Or now that we understand how important it is to have that ideal capsule wrap, it is maybe it's a redundant discussion altogether. No thoughts? No comment?
Yeah, I do have something, ma'am. I just wanted to just discuss about what you just said about, in pseudo exfoliation or basically progressive causes of subluxation, where you can, where you gave the option of putting the IOL in the sulcus and then doing a capture and with a CTR in the bag. The point that I see in that approach is that the IOL is still going to be partly supported by the bag, and the entire bag CTR complex can still subluxate because the subluxation is a progressive cause, and therefore the IOL may also subluxate with time. I don't think that because it's also captured. So I don't know how that is going to actually prevent long-term subluxation. So what I do in these cases, and that's also something that I've published, is the supracapsular glued IOL fixation. So what you can do in those cases is, even when you're doing the I wouldn't suggest it, of course, for mild pseudo exfoliations and things like that, where you would just put a CTR. But for larger subluxations where you don't want to enter the vitreous cavity, for example, a high myope or things like that, then you can do a supracapsular glued IOL and then put a CTR in the capsule so that the whole capsular bag doesn't shrink up. And if you want, you could also do an optic capture. That depends on you. So this will give you a good separation between the posterior chamber and the anterior chamber. There's no, entry of vitreous at all. If, for instance, if you, for example, if you've done a plain glued IOL instead of this technique where you remove the capsule. And also it gives you a long-term, stable fixation rather than having a unstable fixation. So that's my preferred technique in progressive subluxation, which are already subluxated enough and where you don't want to enter the vitreous cavity, where you would like to retain the capsular bag as well.
Doctor, yes, very valuable thoughts. And Dr. Afsar, your thoughts?
I think the vitrectomy part is very important in managing these complicated cases. So for the juniors, don't get carried away with these wonderful videos. Vitrectomy will decide the fate of the eye, and PHAIK and many others pointed out that very well. So please do that. But I want to recognize Dr. Amar Agrawal and his team for forth-through pupilloplasty and intrascleral fixation versus the suture fixation, Gore-Tex and PHAIK and whatever. There's a distinct difference between suture techniques of all kinds, and they are very smart techniques, versus intrascleral. And Gabor Shariat and Amar made it so easy for all of us. And now Yamane even further had a great appeal. So I think that you must understand the value and pros and cons of these two groups of techniques, suture versus intrascleral and this thing. So that's the only comment. Vitrectomy is the key word.
I think there are a lot of questions to ask, but we have to move on because we are running quite late.
If I can say one thing, ma'am, for all the youngsters, like Dr. Vasavda said just now, he has a beautiful video which also won the award. I think something about, choosing. I remember the way the video starts, where you go and the road less traveled. And that shows a very good, teaching. That's a beautiful teaching video about how to do vitrectomy from the posterior aspect and how it draws the vitreous back instead of allowing it to prolapse more and more when you do it from anterior. So if there are any youngsters watching, do watch that.
Yes.